So wonderful to see you all. Welcome to our March Town Hall. Spring is in the air. It's starting to warm up around the country, and at EBRP, momentum is at an all-time high. This is a time of the year where we really start to be in running order. A couple months into the year, we just received our first research cycle of the year that we will talk about. But first of all, just welcome everybody. It's amazing to see every time we do these town halls, just looking around, this is the community that we need to accomplish our mission of treatments and cures for EB. I look around this call and I see faces and I see names. We have family members on this call. We have members of the medical community, doctors and researchers. We have donors, we have supporters, we have board members and leaders. We have folks that are popping in to learn about the mission and the cause for the first time. So it's just so rewarding. We thank you, everybody, for your time to join us today. I want to give some shout outs to the EBRP team that's also on the call: Katrina, Margot, Dan, and Allison, who puts in a tremendous amount of work to organize these town halls and make them possible and bring them all to you. So thank you very much to the team. We have a really inspiring, moving, motivating town hall for us all today. And our focus will be on junctional EB. This was requested from you, the community, to really hone in and focus more on the junctional EB community, the therapeutics, and the families that are impacted by junctional EB. We're going to talk about emerging therapies in the space and really creative ways to rally the community to continue the progress that you'll hear about today. We are very honored to be joined by one of my personal heroes, Jordan Eaves. And if you have never met Jordan, you will never forget meeting her for the first time. She is one of the most brave, courageous, driven parents that has come across our community at EB. She has started Wesson's Wish in honor of her son, Wesson. And every time that you talk to Jordan, I don't know how you find hours in the day, Jordan. Every call shows up with thousands of ideas, all kinds of new opportunities and progress and events and bringing people to the cause, all to honor Wesson. And, you are an absolute force, Jordan, an absolute force. And to spend time and join us today and share your story, we just continue to thank you. So for those that haven't met Jordan, excited for everybody to meet her and learn more about her story. We also have very innovative and dedicated researchers from UMass and University of Southern California. And, I just want to say, when we meet Dr. Reusch, is doing really innovative work in drug repurposing at UMass, which is just a fascinating area, right? What's on the shelf that can be repurposed to help our community, and she's leading the charge on the front lines. Dr. Woodley and Dr. Chen just informed us recently that they have been working together for more than 3 decades. And I remember, learning about the EB community for the first time in 2017. It was your publications that were the first that I've read. It has been probably the most consistent work that we've supported as a foundation for the last decade straight. So these are really, really brilliant innovators and heavyweights in the space. So, and also very busy people, like all of our guests today. So just thank you for spending time with us. You will hear the Eaves family's journey with EB and how they honor their son Weston and his light and legacy. You will hear from Dr. Reusch about her novel drug repurposing work with Ada Lauren. And you will hear from Dr. Chen and Dr. Woodley on groundbreaking research that their team is doing with gentamicin to improve and impact the lives of those living with junctional EB. And EBRP is a proud supporter of all of these projects and a proud partner of all the many, many annual events that you'll hear about from Wesson's Wish. To provide an overview of today's event and our town hall for those that are new, just out of respect to the speakers, we've collected questions in advance and we're going to prioritize those questions. But please, the town hall is for you and for the community. So if you have questions, you can drop them in the group chat. If you'd feel more comfortable to send them to us directly, you can send them to Allison McGettigan from our team. We will do our best to answer each and every question with the time allotted. If for any reason we don't get to those questions, fear not. You can email them to us afterwards. We'll collect all those questions, and in response to this meeting, make sure that we can answer all of your questions and get back to you, whether that's from the EBRP team directly or for any of our guest speakers today. Before we jump right in to this incredible panel, I want to start, for those that may be new, with some background on EB Research Partnership. EBRP is the largest global nonprofit funding research to treat and ultimately cure EB. Since we started, we've raised over $70 million to fund more than 160 innovative EB projects all around the world. Approximately 90 cents on every dollar is donated directly to EB research projects and funding research. And the work that we've done at EBRP has helped, along with many brilliant scientists and doctors, including many of which we have on the call today, has really transformed the landscape. We've gone from 2 clinical trials to now almost 50, over half of which EBRP is directly supported. And, most importantly, we've gone from 0 treatments to 2 FDA approvals in 2023 alone. And I think many of us wait in anticipation because there is a third FDA approval from Abeona that is up on April 29th PDUFA date. So definitely something that we have our fingers and toes and all the positive energy put out into the universe that has the potential to be our third FDA approval. And while the momentum is incredibly exciting, it wouldn't be possible without all of you on the call, the community that it takes to accomplish this work. And treatments are a big milestone, but they're just that. They're a stepping stone on the journey for a cure, which is our ultimate goal. And we will not stop until we deliver a cure for each and every family member, each and every patient with EB. And to achieve this goal, we continue to fund the most innovative research around the planet. We funded 22 different countries, all subtypes of EB, a diverse portfolio of different shots on goal, from gene editing to gene therapies to protein replacement therapies to immune therapies to messenger RNA to squamous cell carcinoma treatments, and many, many more. We're very proud to announce we just received our first cycle of the year that's currently under review by our scientific advisory board. 12 applications, $3.6 million, and ask 10 institutions, 5 countries. And, what we continue to see a rise of and the applications year over year is a diverse portfolio of research techniques for all different types of therapies for every subtype of EB. One of the things that I think was a big standout and an all-time high for this cycle is almost half of the projects that we receive by medical definition have the potential to be curative for EB. Now, this is an all-time high as far as a percentage. So when we talk about the ultimate goal of curing EB once and for all, massive momentum and progress. And these are self-identified by the researchers that apply that these projects have the potential and capability to actually be curative. So that's an all-time record as far as the percentage of projects that we've received. And we also ask the scientists and medical professionals that apply, does the science have the ability to have an impact beyond EB? And this cycle above 90%. So the focus is on EB, but knowing when we're talking about things like gene therapy, gene editing, messenger RNA, protein replacement therapies, they also have the ability to impact other indications beyond EB. Now, of course, there's lots of ways to get involved and support. We'd love support from the community in any way that you can, whether organizing an event, donating, getting involved in a way that works for you. I do want to acknowledge, as we evaluate projects which to fund, of course, we need the funding to be able to do that, but we do have somebody on the call, Dr. Jeff Heddles, and I saw you, Jeff, and I'm thinking, yep, Dr. Jeff is still on the call. So I just wanted to give a very big shout out to Dr. Jeff Heddles. Right now, Jeff has stepped up to match every single donation up to $250,000. So whether it's at an event, whether it's a donation you make directly, whether you get your company involved, every penny is matched, every dollar is matched dollar for dollar up to that amount. So big shout out to Dr. Jeff Heddles. If you're on the line, Jeff, and you can hear us, I don't know if there's anything that you wanted to add, but just wanted to acknowledge you for your generosity and your support.
Nothing much to add, Michael. Just keep going, guys. It's exciting stuff.
Awesome. He is a humble man, but thank you, Jeff. Greatly, greatly appreciated. Well, without further ado, it is now my pleasure to introduce you to our amazing speakers today. We are honored, profoundly honored, to be joined by an unstoppable EB advocate, a force in her community and the global community, an all-around badass, if you don't mind me saying, Jordan. Jordan, we first met in Fredericksburg, Texas, and I remember just being blown away by your energy, your determination, your grit, your force, your relentlessness, your resiliency, your advocacy. And nothing can stop you, Jordan, absolutely nothing. And you inspire us every single day to bring that energy into our work. So just thank you, Jordan. Really, really grateful for you for joining us, but also for the rest of the community to get to know you more and know your story. We also have the amazing Dr. Reusch from UMass Chan Medical School, who's an associate professor of dermatology at UMass and passionate about caring for patients with connective tissue diseases, including epidermolysis bullosa, and hopes to advance both clinical care and research in these fields. Last but certainly not least, the aforementioned Dr. Chen and Dr. Woodley from the University of Southern California. Dr. Mei Chen is a professor of dermatology at USC and the director of USC's Laboratories for Investigative Dermatology. Her research is focused on the structure and function of type 7 collagen and developing various therapeutic approaches, including cell therapy, small molecule-based drug therapy, protein therapy, and gene therapy for the treatment of EB. And Dr. David Woodley joined USC as a professor and co-chief of the Division of Dermatology in 1999. In 2005, dermatology became an independent academic department, and Dr. Woodley was appointed professor and chair of this new department, where he remains today. Dr. Woodley has expertise in wound healing and gene therapy for EB and has published over, and I'm going to pause, 165 scientific papers. So a huge thank you to our speakers for taking the time to join us today. And with that, it is my pleasure to pass it over to the heroic, amazing Jordan Eaves.
Wow, thank you for the introduction. I always tell people whenever they give me compliments like that, if you lost a child to this horrific disease, you would be doing the same exact thing I'm doing. We just feel honored to be called to be his parents and that we are able to carry on his legacy. So I think I'm only allotted 10 minutes. I can get long-winded, so I'm gonna keep watch of the clock and make sure I stay on time. But here are just some pictures of our family. I'm gonna start off with a little bit of our story. Our story is a pretty detailed one, even though our son's life was only 51 days. We saw so much happen in those 51 days time. Our son was born by cesarean delivery at July 15th of 2021. At the time, we only had a 21-month-old daughter, and then he was born. He was born completely normal. There was a little tiny scratch above his lip, and that was what we thought was a scratch, and that was all I really saw. 36 hours later, there was a lesion on his elbow that my husband noticed, and that's kind of when our whole entire world shifted. I was actually taking my first shower post-delivery when the nurses came rushing in and took him away. Their original diagnosis was thinking that it was some types of sexually transmitted disease, which obviously was very alarming to me and my husband, as we do not carry any of those things. So that was something I hope parents never have to go through. And then it just started all the medications, all the questioning. My husband actually Googled and found EB and questioned one of the nurses at the hospital we were at about it. And she had said that she had seen so many cases of EB and our son did not have that. And so it kind of left us like, okay, so what is this then? We advocated for him and got pushed to a hospital or transferred to a hospital in downtown Houston, which is an amazing, amazing hospital. And we were actually put in the hands of a nurse who actually had been there for Brady. And it just became an amazing story in that moment. She's still one of our dear friends, but we were there about not even 24 hours and they told us he had EB. So for then we just started the research. They were pretty certain he didn't have a terminal before the age of 1 case. And just because of how well he was presenting. And then we learned, I think it was day 48 of life, 47 of life, that he did have JEB Hertzlitz. That meeting was something I will never, ever forget. They called it a family meeting, and we met doctors and nurses who weren't even on shift, came up there for the meeting, and it was a meeting that I'll never forget. They told us what our son had, and we had already done the research and knew that that meant he was terminal. And it was devastating. We stayed every single night after at the hospital with him and had to make the call to take him off of life support when we just felt like his quality of life was non-existent. We are huge believers in Jesus, and we felt him every step of the way, and actually felt Jesus, as crazy as this sounds, we felt Jesus come and take him. We knew the second that he took his last breath. And in that moment, we just knew that we had to do something. We had to keep going, and we had to carry on his legacy, because if we didn't carry it on, who would? And we then just started realizing there's so many parents who are dealing with this on a daily basis, and they want to be loud voices, but the intense care that goes on with EB, I think, limits them for how loud they can be, because they have so much going on in their home. So we felt like with our son being in heaven and not having the day-to-day EB things going on, that we had to be a voice for all those parents that wanted to be a voice, that are so wrapped up at home with all of the things of EB. So that's how Wesson's Wish was formed. Our son's name was Wesson. We held our first event in November of 21. It was for the Ventures of a Cure. I didn't even know really what was going on, really even what EBRP was, honestly. We just got connected, and I was like, okay, cool. This is like, it was literally on my birthday, and I didn't really want to celebrate my birthday. So I was like, this is perfect. We'll just do this instead. So some of our friends offered to host it at their house, and we raised $50,000. And I was not expecting that at all. And so from there, we decided to formulate Wesson's Wish, which formulating a nonprofit was way more work than I thought, but we did it. And now we have, so yeah, these numbers up here, sorry, I got to stick to the script. Okay, so we have raised $218,000 since November of 21. And then this year we've already raised almost 26,000, or a little over 26,000. So I had a big goal last year of 100,000. We didn't meet it, but I really think that we'll be able to meet it this year. So through, I think the next slide is the events, I think. Yeah, okay, so this is one of our annual events. We just had our second annual in October, and we have the next one booked. So for anyone that wants to come to Houston, Texas, our next event for golf is October 21st. I haven't even told EBRP because we just signed the contract a couple days ago, but October 21st of 2025 will be our third annual. So my husband really wanted to do a golf tournament, and he just felt like it could bring us a lot of money, and he was right. So I did not even know like what par or anything was. I was over here planning a golf tournament. The thing that I would say when it comes to events like this is to do what your community is into. And we have a lot of people here in Texas, it is hot almost all the time, that love to do things outdoors. And so golf is one of the things that we really leaned into. I just started asking all of the clubs around who would give us the best pricing. We don't play at the prettiest course, but we play at a course that we know is local to everyone, that supports our mission. And we have donors. EBRP always donates a poster for us that's signed by Eddie Vedder. We usually do a liquor pool, which is super fun, where basically you pay for a ticket, and then it matches to a number on the liquor. And so it can be something as great as a great bottle of tequila, or as not good as just, something very cheap. So we also get that all donated as well. Our goal is to spend as least money as possible. So we try to make sure everything's donated, sponsored, all of that. You can see in that second picture, one thing I did recently is we have a dedicated volunteer team. I was getting very tired of just constantly trying to ask for volunteers. And so instead I picked 15 people who I knew are really connected to Wesson's Wish, or our son, or us, and asked if they would be on the volunteer team. So they have specific shirts that they wear to our events. That way I'm not having to buy a new shirt every event and take money out of the cost. And then they are official volunteers that I go to first for all of our events. And then you can see in the bottom right, we do fun things to just make it. That's actually my in-laws own a plumbing company, and so they sponsored a hole. And so they had they had a toilet seat, and then people had to hit the ball and use the toilet seat as like a backdrop or a backboard to hit it into the hole. And so you can see people kind of moving it around the hole. We take team pictures, and then when I write every team thank yous, I send a picture of their team with a thank you, just trying to make it as personalized as possible so that people want to come back. And then, okay, now we also do a clay shoot. So we just had our second annual clay shoot. this year went way better than last year. Again, I just take anything that anyone tells me and I apply it, because I know that I am still always learning. And so last year, a lot of the shooters, clay shooting is a huge thing here. Some people don't know what clay shooting is. It is basically where the best way I can describe it is a machine shoots out like orange disc, and then you shoot it with a shotgun, and you're trying to shoot as many as possible. Is what a clay shoot is, right? Is that a good way to explain it? Okay. And so that is a big thing here in Texas. And so there's also a lot of money in people that like do sporting clays, like as a hobby. There's a lot of people who are wealthy in that. So I was like, okay, we're going to push into this and try to get some big donors here. So this year we had a very successful event. I cannot remember off the top of my head how much we raised. I think it was almost 30,000. But we did things like the belt buckles. It's a big deal to have belt buckles. Someone told us last year, you've got to have belt buckles. So we did that this year. We do fun trophies. It's called Dead Ass Last, and they love these. So whoever gets last at the golf tournament or the clay shoot get these like bobblehead donkeys where they're like butt shake for Dead Ass Last. That's been a huge hit. Something really special this year was my daughter, actually, who's now 5. She really wanted to do something for her Bubba, and she made a lemonade stand and made cookies, and she actually was able to raise over $1,000 off of cookies. So the input of that was like $1,865, and we raised $1,000. So just really trying to make it, like I said, unique to your event. Also recognizing sponsors by having those banners like you see, and making sure that you are raising awareness. We also have a really nice gun that we had for auction, or not auction, as our raffle item. And that's the only raffle item we have at the clay shoot. At the golf tournament, we have more, because we realized that the clay shoot, the people there were not as into it as they were the golf tournament. So every year we're kind of changing things as we go and figuring it out. But those are 2 big events that we are annually doing. This is something that a family friend came to us about. Anyone who comes to me and says they want to support Wesson's Wish, I'm like, tell me how you want to do it. So these are some amazing family friends of ours. They did a family fiesta. So they invited all their close friends and family, and they were so gracious, and they fronted all the costs. So we just collected all the profit from donations. And basically it was people just came, donated at the door what they felt led to. And then my dad's band was there. We had bounce houses, we had Connie's custard, and it was just a fun time. And we made around $7,000 for that event. So my thing is always just being able to take ideas that people already have and put them into place, and not always just have to stick by the book and kind of what it's always been. I doubt we'll do this event again, just because that would be a lot asking them to do this every single year, but to raise $7,000 and raise more awareness, and we've made more partnership from that. This was super successful and fun to get everyone involved in this event. Okay, this is something else we knew we did this year. Apparently, I'm not supposed to call it Super Bowl squares, so that's something I learned because so no one get at me for that, but I will change it for next year. But this was super fun. My husband thought of this. My husband actually would be on this call, but we, by the grace of God, have a 7-month-old through IVF to avoid EB, obviously. And so he is downstairs with him, but he is always the like brains behind these. I am just the face and like putting this into practice. So really kudos to him, because he's truly the brain behind the operation. But these were super fun and so easy. Okay, we want to do like 2 to 3. I wanted to do March Madness this year, but I didn't get around to it. But Super Bowl squares was so easy, and I just posted this online on we have a Facebook page and then on my regular page, and I try to get people to share it. And then every $50 they got a square. I put their name in there, and then if they won, they got to pick a prize. So the prizes were about $1,000 total, but then we made about 4,200. So we didn't fill every square. So any square we didn't fill, we just put a Wesson's Wish butterfly And whatever, if we picked that square, then the money just went back to the nonprofit. My husband's idea, which I thought was genius, so I wasn't stressed about filling them all. And then y'all, 3 out of the 4 winners told us they didn't want a prize. They just wanted us to keep the money. So it was really cool because we were only out like $250 and a little work on Canva, and that was it. So that was a really fun way to just raise money without having to be an in-person live thing. And next year, I want to do March Madness brackets as well, and get those going too. I was supposed to do that this year, but it's a little crazy with 7-month-old and everything else we have going on. So, but this was our Super Bowl squares. Okay, and then this is just some more pictures. Basically, I already kind of talked about this, but if we aren't vocal, then who else is going to be? I think so many people all the time like see me as so strong, or they use that word all the time, or like, you're so inspiring, and I just really believe that me and Jake, like I said, since our son has gone to heaven and he is free from pain, and we are so thankful for that. But we have to be even louder because we went through something that I would not wish on my worst enemy. And I just think, like I say, my heart breaks, honestly, for the families that are having to watch their child be in pain every single day. And as they get older, I mean, I've been around some of these kids, but just it leaves me speechless, to be honest. And so I know that even these parents who have kids living with EB, they're still using their voice. And I know that they wish that they could be louder and do more, and they just physically can't because of what they're required to do at home. And so me and Jake just feel like we have a job and a mission to fill that gap and try to be as loud as we can in their spot. And if we aren't loud about it, who's going to be? Because most people don't even know about EB. And we have found that out through that nurse that told us she had seen a ton of cases. We found out that was completely false. And so we are the ones who just really have to be loud and vocal about EB and finding a cure. I think that's it.
Thank you so much, Jordan. And, you know, I think you understand, everybody on this call, what we mean when we say that Jordan is a force. And if you're looking for the Cliff Notes, bullet points, any given month that you're in Texas, Jordan has something going on. So please find ways to support her and Wesson's Wish. And Jordan, you talk about being vocal and being loud and using your voice, and what you've done to carry the torch from Wesson for families today and to support families today, uniquely knowing what it's like, but using your voice and using that loudness and using that power to really define what selflessness is, which is giving to something greater than yourself and something that, you know, unequivocally is going to help other people, right? And I think about you a lot, and I see on the call we have, you know, Katie on the phone, and we have Ann on the phone, and there's this group of parents, and you 3 specifically, right, in honor of Wesson, in honor of Sophia, in honor of Hallie. You continue to march on, and your work not only is loud and is not only vocal and not only raises awareness, but, you know, the next half of this town hall, you are raising funds to support work in Junctional, and you have made an incredible impact. When I joined this organization 7 years ago, we weren't supporting projects in Junctional EB, and the researchers and clinicians we're going to hear from next have led the charge. But you know, brass tacks, as simple as possible, would not be possible without the awareness and support and dollars and these families have raised. And I see you, Katie, and Ann as well. And that is rare air of parents that spend your energy and rally those communities, as you said, Jordan, to actually make an impact and drive change and progress in real time. So just a tremendous thank you so much, Jordan, for everything that you continue to do. And I also see we've got some board members on the phone from other countries. I see Rick and Nathan, and they're not familiar with clay shoot. So I'm going to make them come to Texas next year, Jordan, count us in so we can show them how it's done. And you guys got to do a little better than what's the donkey prize, ass last?
Dead ass last, but now people like want that prize. Okay, they're like not trying to win first, they want the bobblehead. Actually, the whole group from our church won it this year, and our pastor was on the team, and he was so excited. It's sitting in his office, and so I don't know.
Well, yeah, something to aspire to at the top or the bottom. And just thank you so much, Jordan. A perfect segue to the work that you're helping make possible and this whole community is making possible. It is my pleasure to introduce from UMass, Dr. Reusch.
Hi, thank you guys so much for inviting me today. It's really an honor to be here alongside Jordan, Dr. Chen, Dr. Woodley, everyone from EBRP, and all the family members and supporters who are here listening in the audience. I'm going to be talking about a project to treat people who have epidermolysis bullosa with a drug called Ataluren. Ataluren is a small molecule treatment that allows for read-through protein expression from the DNA. And I'll start briefly by reviewing how genes make proteins. So DNA is the instruction manual that tells your body which amino acids, aka building blocks, should be made. DNA comes in a long sequence made up of 4 nucleotides that are represented by the letters A, T, C, and G. And the sequence gets converted to RNA, which is like a photocopy of the instruction manual that can be brought on over to the protein building block factory, also known as the ribosome. And then the genetic sequence gets read out in groups of 3, where each 3 letters or nucleotides codes for a different amino acid. Based on your genetic sequence, your body knows exactly which amino acids or building blocks to make to form larger proteins that make you you. Your genetic sequence also tells your body when to stop making proteins. So there are a few 3-letter combinations that serve as stop signs for protein production, and these are necessary and important for all people. However, some people have premature termination codons, which we abbreviate to call PTCs. With PTCs, stop signs are occurring too early. If a stop sign occurs too early, then necessary protein production is halted, and there's some people with EB whose disease is caused because of these PTCs. We see this in all subtypes. So some people with dystrophic EB have PTCs, whereas others don't. Some people with junctional EB have PTCs, whereas others don't. And some people with EB simplex have PTCs, whereas others don't. There are many different types of mutations or errors that can lead to disease, and PTCs are just one specific type. So Ataluren is a medication that allows for read-through of these premature termination codons. Instead of stopping at the stop sign, Ataluren encourages your body to run the red light and continue making functional protein. And the next slide. So Ataluren, it's currently an approved treatment in Europe for patients who have Duchenne muscular dystrophy. And Ataluren did not gain the approval for the same disease in the US because study endpoints were not met in the trial. Because the study endpoints were not met, there was some uncertainty about the effectiveness of the drug, and so it's not FDA approved for Duchenne here. There are many other diseases in addition to Duchenne and EB that are caused by premature termination codons. So researchers have tried Ataluren for a few different indications, including cystic fibrosis and a few other rare genetic disorders. In all of these trials, there have been some promising signals, but results and the endpoints that have been set out by the researchers at the beginning of the trials haven't been met. So Ataluren currently does not have approval for any indication in the US right now. So generally, Ataluren is a very well-tolerated medication. It comes as a powder that you can mix with liquids or foods. It's vanilla flavored. Some people think it's a little bit chalky tasting, but generally, a lot of people take it and don't have side effects. There's occasionally some stomach upset, nausea, other minor side effects, but the reporting of serious side effects with the Ataluren is very low. However, long-term data is unknown. So the medication was only starting to be used in 2014. So we don't have decades and decades of long-term experience about potential adverse side effects that you might see for a drug once it's been out for longer. So I'm very grateful for the EBRP for supporting our team at UMass to trial Ataluren for patients with EB. We have one patient with junctional EB who started Ataluren therapy in 2019, and he continues on therapy now more than 5 years later because he hasn't found it very effective. We are currently underway to treat 3 additional patients with Ataluren. And so we have FDA approval to treat 1 woman who has EB simplex with muscular dystrophy, 1 gentleman who has junctional EB of the intermediate type, and 1 teenage girl who has recessive dystrophic EB. Before I tell you more about our Ataluren research, I'd like to pause and give a special thanks to Dr. Karen Wiss. Dr. Wiss started the EB clinic at UMass, and she's been an incredible mentor to me. I worked with Dr. Wiss as much as I could during my dermatology residency to learn more about EB, and I took the job at UMass so I could continue to do EB work with her. Dr. Wiss retired this past July, and I now have the privilege of leading our EB clinic, but she remains a very important mentor to me. And she did all of the groundwork to help get this Ataluren therapy for our patients, and I'm only able to continue in this work because of her tireless effort. In addition to Dr. Wiss, it really takes a whole village to do research, so I'd like to thank our whole team. Doctors Amano and Orlowski helped conceptualize and start this project for our first patient who was treated starting in 2019. Dr. Servatilab is currently a pediatric dermatology fellow at Boston Children's Hospital, and she, along with Carolyn Foley, really led the charge in helping to plan the project to treat our 3 additional patients. George Kwapong is a postdoc research fellow in our lab at UMass who is coordinating care for the 3 additional patients who are receiving treatment. And Celia Hardigan is our research nurse who we couldn't do any of this research without. We're also collaborating with Dr. Mei Chen from USC on this project, who you'll hear from next. So back to Ataluren. The first patient that Dr. Wiss treated, who I mentioned had junctional EB, he noticed wound healing and improved quality of life pretty soon after starting Ataluren. In this figure, you can see a dramatic decrease in his hospital encounters over time. So in the 2 years leading up to Ataluren treatment, he was admitted to the pediatric intensive care unit, the general hospital wards, and had several emergency room visits, which are represented by the orange, blue, and green diamonds. But as his Ataluren treatment continues, which you can see starting at the day 0 mark, where that first light green box starts, that's where his hospital encounters start to decrease. So with more than 5 years on this medicine, he hasn't really had any side effects, and he's noticed dramatic improvement in his quality of life. So with the promising results that this first patient had, we wanted to treat more EB patients who have premature termination codons with Ataluren. This is not as simple as it sounds, though. Because Ataluren is not FDA approved for any indication in the US, you can't just send a prescription to the local pharmacy. First, the FDA has to give investigational new drug approval for every single patient that we want to receive medicine on a compassionate use basis. Next, we need the sponsor company who makes the Ataluren to agree to distribute the drug on a compassionate use basis. And then we also need our UMass Institutional Review Board, or IRB, to approve our treatment plan. So as of right now, we have 3 INDs that are approved for the 3 EB patients I mentioned, who are 3 patients who are known to our clinic, who are known to have premature termination codons, and who were interested in the therapy. The company that makes the Ataluren has promised to give drug for all of these patients that we currently have the INDs in place for. But unfortunately, the sponsor is not accepting applications for new compassionate use repurposing at this time. So unfortunately, that means if you're here listening to this talk and thinking you might want to pursue Ataluren therapy for yourself or someone in your family, we do not have ability at the present time to expand our Ataluren research to additional participants. We do have IRB approval from our institution, though, to treat the 3 patients that already have their INDs in place. And one of those 3 patients just came in last week and consented to start treatment. So our study plan for these 3 patients who are receiving Ataluren treatment in this kind of the second phase of our treatment is as follows. We monitor safety labs every 3 months. We follow skin examinations with digital photography to track wound healing. And we compare patient-reported outcome measures at 3-month intervals. We're taking skin biopsies at baseline, 6 months, and 1 year, and we're sending these over to Dr. Chen at USC, who's helping us to try to quantify protein expression in the skin so that we have another data point in addition to patient outcome reports and photography as to how well the Adalurin is working to really increase that protein expression in the skin. And we have an internal checkpoint set for ourselves at 6 months so that we can check in with these endpoints and talk with the patient about whether we think the medicine is working or not and whether it makes sense to continue for the next 6 months of therapy. So in summary, I'll highlight the following key points. Premature termination codons are the genetic cause of EB for a subset of patients who have all different EB subtypes, including junctional EB. Adalurin is a read-through therapy that is not FDA approved in the US, but is approved in Europe for Duchenne's muscular dystrophy. We have one patient who started Adalurin on a compassionate use basis in 2019 who had excellent improvement, and this inspired our current investigation to study treatment response in 3 additional patients at the UMass EB Clinic. We do not have ability to treat additional patients with Adalurin at this time, but I hope that our current investigations lead to greater understanding and availability of read-through therapies that will benefit many additional patients with EB, as well as other genetic diseases. And I think if we have really, really promising results, there's definitely an argument to be made that we can try to work to get more compassionate use or maybe do a formal clinical trial for the drug for EB. So thank you so much for your time and attention today. It's really so wonderful to be here.
Dr. Reusch, just a very big thank you to you and your team at UMass. You've highlighted, the hope and opportunity, but you've also highlighted the challenges. So just thank you for your team to never give up and continue to really break down walls and break down barriers to advance this treatment. I mean, to accelerate a low risk, low cost, high efficiency, but high impact treatment for EB is massive, and really to take an innovative approach of finding things that can be, therapeutics and drugs that can be repurposed and off the shelf to have immediate impact for the EB community. Just a tremendous thank you. And again, a good segue, thanking your mentors and collaborators, including Dr. Mei Chen. So with that, it is my pleasure and honor to pass it over to Dr. Mei Chen and Dr. David Woodley from USC.
So we have a talk on read-through therapy for EB, and Dr. Reusch really outlined a lot of the pathogenesis and the meaning why this might work. Can I have the next slide? So for some reason, these slides are a little different than the ones that I have, but nonsense mutations account for 30% of the mutations in recessive dystrophic EB and 80% of the mutations in junctional epidermolysis bullosa. Nonsense mutations stop gene translation early, leading to an incomplete or non-functional protein. Usually the protein that is made is smaller than normal and not functional. Gentamicin can bypass these mutations and restore the production of full-length junctional proteins. Gentamicin is an old drug. It can be used topically or systemically, both by IV and intramuscular use if you want to give it systemically. And it's already approved, as many people know, as a potent antibiotic for patients that have infections. Next, please. This schematic demonstrates how gentamicin helps bypass a nonsense mutation. In the top panel, a nonsense mutation causes premature translation termination, leading to, as I said before, a truncated, smaller, non-functional protein, such as type 7 collagen for patients with RDEB, and the laminin beta 3 chain for patients with junctional EB. The bottom panel shows how gentamicin enables translation to proceed beyond the mutation, resulting in the production of a full-length functional protein. This process corrects EB phenotypes in vitro in the laboratory. It increases levels of laminin 332 and type 7 collagen in vitro, and it enhances the wound healing in human patients. Next, please. We first examined the feasibility of gentamicin treatment in cultured RDEB cells that had nonsense mutations. Now, this preclinical study was a crucial step in translating our laboratory discoveries to patient application. Next slide. This slide showcases our preclinical findings in RDEB cultured keratinocytes. We treated type 7 collagen deficient keratinocytes and fibroblasts derived from RDEB patients with increasing doses, as you can see here, of gentamicin, leading to a dose-dependent production of full-length type 7 collagen, as shown in the top panels. For those who maybe don't know about type 7 collagen makes these anchoring fibril in the skin, and between the epidermis and the dermis, we have anchoring fibrils that hold those two layers of skin together. And those anchoring fibrils are made of type 7 collagen. So that's why it's such an important protein. In an in vitro skin equivalent model, the bottom panel, we observed that gentamicin induced type 7 collagen that successfully integrated where it's supposed to be in the dermal epidermal junction between the epidermis and dermis, as you can see in these panels. Next slide, please. Building on these in vitro results, we enrolled 5 RDEB patients with nonsense mutations into a double-blinded, placebo-controlled clinical trial. 5 RDEB patients received treatment with 0.1% topical gentamicin 3 times a day for 2 weeks. We demonstrated that gentamicin induced the production of new type 7 collagen in these patients, with effects lasting up to 1 to 3 months post-treatment. In addition, wound healing was significantly improved in these patients with enhancement of closure and durability to keep the wounds closed. And there were no signs of any side effects, and there were no signs of the generation of anti-type 7 collagen autoantibodies, even though this was a new protein in the patient's system. Next slide. This slide illustrates that topical gentamicin induced the production of new type 7 collagen and anchoring fibrils, leading to improved wound closure. Prior to the treatment in the first row to your left, and 1 month after receiving a placebo, the second row, all 5 RDEB patients exhibited minimal to no type 7 collagen at the dermal epidermal junction. In contrast, gentamicin-treated wound showed significant type 7 collagen at the dermal epidermal junction 1 month after treatment, the third row, with this effect lasting up to 3 months, the fourth row. The increased expression of type 7 collagen led to the formation of anchoring fibrils, the upper right panel. This is our electron microscopy showing these anchoring fibrils. And this contributed to enhanced wound closure, while the placebo treatment wounds failed to heal, as shown in the bottom right panel. Next slide. Topical gentamicin is a localized treatment that does not address the widespread systemic manifestations of the disease. As you know, RDEB patients have wounds all over their body. So we next explored whether we could deliver the gentamicin intravenously, and whether intravenous gentamicin could provide a systemic solution for treating all the blisters and all the erosions simultaneously. In this trial, RDEB patients receiving IV gentamicin demonstrated new type 7 collagen induction lasting 1 to 3 months post-treatment, improved wound closure, and reduced blister formation, and overall clinical improvement. And again, no side effects. And most importantly, no anti-type 7 collagen autoantibodies were generated. Next slide. This slide presents our results in RDEB patients. As shown in the top panels, patients had little or no type 7 collagen at baseline, day 1 to your left. After 1 month of gentamicin treatment, type 7 collagen levels increased in both wound sites and intact skin. So wound sites are labeled W and intact skin is labeled I in this slide. And this effect persisting for up to 6 months, you can see out to your right. The bottom panel displays representative photographs of the monitored wound sites in these patients at dates 0, 1, and 3 months after treatment for patient 1 and patient 2. Notably, all wounds showed significant closure at both 1 and 3 months following IV gentamicin. So I think that's my last slide, but just in summary, this shows that topical and systemically administered by intravenous administration, gentamicin-induced new type 7 collagen in RDEB patients. And in that one slide I showed you, that these new type 7 collagen also form anchoring fibrils, and this promoted wound closure in these patients. So that's it. That's the end.
Well, just a tremendous thank you, Dr. Woodley and Dr. Chen, not only for your work in gentamicin, which I think I mentioned, this has been one of the longest standing projects that we've supported at EBRP, but more importantly, for more than 30 years of commitment to the EB community. We just thank you so much. We're very lucky as a community to have brilliant researchers, scientists, and clinicians like yourself dedicated to the EB community. So just a very, very big thank you. I'm going to go ahead and jump right into questions. We received a lot in advance, so I'm going to try to get through as many as possible. But just a reminder to the group, if you have questions, drop them in the chat. If you feel comfortable, if you'd rather send it to our staff directly, you can send a direct message to Allison, and we will get through as many questions as we can. But again, assure you, if we can't answer your question today, we will be sure to follow up afterwards. So this first question is for Doctors Woodley, Chen, and Reusch. Is there any correlation with any of the EB subtypes in inflammatory responses with regards to certain foods? For example, does adding certain foods or subtracting certain foods elicit changes in healing?
Michael, we have 5 more minutes to talk on junction EB.
Sorry, say that again, Dr. Chen?
Minutes talk on junction EB. So David talking about recessive dystrophy. I will present the study on junction EB. So do we still have time or no?
Yeah, of course. We absolutely have time. Absolutely.
So can I give my talk in 5 minutes?
Yeah, take your time, Dr. Chen. We're here for you.
So now I will present our study on junction EB with mutation in gene encoding laminin 332. So it's important to note that approximately 80% of JB patients have nonsense mutation, and no effect treatment options are currently available, unlike RDB. There are 2 FDA-approved therapies available. So we first assessed the feasibility of using gentamicin to treat JB in culture cell harbor nonsense mutation. So in summary, our study showed gentamicin induced suppression of JB nonsense mutation, restore laminin beta-3 expression, and enable the functional incorporation of laminin 332 into a dermal-abdominal junction. Next slide. Next. So this slide showcases our preclinical data using JEB cell. We treat the laminin beta-3 deficient keratinocyte derived from 2 JB patients with escalating doses of gentamicin. So this results in a dose-dependent production of laminin beta-3, as shown in top panel. In an in vitro skin equivalent model shown in the bottom panel, we observed the incorporation of gentamicin-induced laminin 332 into a dermal-abdominal junction. Next slide, please. So building on this promising preclinical data, we conducted a clinical trial, treated 3 JB patients with 0.5% topical gentamicin for 3 times daily for 2 weeks. So the same schedule as RDB. So we found that the gentamicin induced new laminin 332 with effect lasting 1 to 3 months post-treatment. and treated wound exhibit improved closure and durability, and no side effect or anti-lamina 332 autoantibody were found. Next slide. So this slide shows example of clinical trial result. As seen in the left panel, in the patient one, expressed very minimal lamina 332 at the dermal abdominal junction or the wounded skin in the first row. 1 month after topical treatment in second row, lamina 332 expression increased and persist for up to 3 months in the third row. So right panel shows that gentamicin treated wounds were closed by 1 and 3 months. Next slide. So our study demonstrated the effectiveness of topical gentamicin. However, JV patients with lesions in areas that are difficult to reach, such as the air mucosa, may benefit from systemic treatment. So in this study, 5 patients received IV gentamicin, 3 at 7.5 milligram kilogram for 2 weeks, and 2 at 10 milligram kilogram for 1 month. So our study found gentamicin induced the production of new lamina 332 with effect lasting up to 3 months and improve wound closure and enhance quality of life. And we do not see any adverse effect. Here is example of our result. At day 0, all patients had a low undetectable lamina 332 at the dermal abdominal junction. 1 month after receiving IV gentamicin, biopsy revealed increased lamina 332 expression. The bottom panel represents photograph of the monitor wound site at day 0 as well as after 1 and 3 months after treatment. As you can see, all monitor wound sites exhibit improved closure with IV gentamicin. Next slide. So in summary, we demonstrated topical short-term intravenous gentamicin promote the nonsense mutation through restore type 7 collagen lamina 332 and improve the wound healing in EB patients. However, long-term use of high concentrated gentamicin is limited by potential ototoxicity and nephrotoxicity. Thus, a gentamicin derivative with great visual activity and reduced toxicity is highly desirable. In a more recent study, we showed that the ELAST-DR2, a novel amyl glycose analog, can induce type 7 collagen lamina 332 in RDB and JB cells, outperform gentamicin in promoting PTC reach-through. We also found that the ELAST-2 induced type 7 collagen lamina 332 correct EB associated abnormal cellular phenotype and integrate into a dermal abdominal junction. Next slide. So here, investigate whether ELAST-2 induced type 7 collagen or lamina 332 could integrate into a dermal abdominal junction of 3D skin equivalent model, as shown untreated RDB or JB skin equivalent. So no detectable type 7 collagen or lamina 332. In contrast, strong linear staining for type 7 collagen left panel and lamina 332 right panel was observed at dermal abdominal junction in skin equivalent, treated with either gentamicin or ELAST-2, resemble the stain pattern seen in normal cell. Last slide. Next one. So in more recent study, we are testing small molecule compound that can enhance gentamicin visual activity while minimize its toxicity. As illustrated in this schematic, translation termination factor such as ERF1A and ERF3A play a crucial role in recognizing nonsense mutation and halting the translation prematurely. Inhibiting any of these factors can promote the nonsense mutation with findings from EBRP. We are currently evaluating 2 reagents, CC9009 and SI14315, both individually and in combination with gentamicin to promote rescue in patients with EB have a nonsense mutation. Last one. So implication for our study. So topical intravenous gentamicin treatment could provide new low-cost, easy-to-use, and non-invasive option for treating patients with EB who have nonsense mutation. Since more than 80% of patients with JEB have nonsense mutation and the condition is severe, often lead to early death with no effective treatment, starting rescue therapy right after diagnosis could be vital for the most severe JEB cases. Lastly, our preclinical study and other research agents with greater efficacy and reduced toxicity are promising. So thank you.
Thank you so much, Dr. Chen. And again, Dr. Woodley and Dr. Chen, not only your work in gentamicin, but 3 decades of service and leadership in the EB community. And Dr. Woodley and Dr. Chen, we received a lot of questions in advance of this town hall, which we'll get to, but I did want to share, we received several comments from families, particularly who had young children with junctional EB, that just wanted to thank you both for the support and care that you were able to offer their children. So I just wanted to make sure to share that with you, and thank you so much for your work and dedication to the community. Just to jump into the questions, to go back to that first question that we received, and this goes to all the doctors on the line, Doctors Woodley, Chen, is there any correlation with any of the EB subtypes and inflammatory responses with regards to certain foods? For example, does adding certain foods or subtracting certain foods elicit changes in healing? And again, Dr. Woodley, Dr. Chen, and Dr. Reusch as well.
I can start, at least with, in general, recessive dystrophic EB and even dominant dystrophic EB. They're relatively, if you biopsy the lesion, they're relatively non-inflammatory overall. Of course, so you can, once you have a wound, if the wound gets infected, then there is an inflammatory response that's quite exuberant. But I don't believe there's any kind of foods that would ratchet down the inflammation in wounds that became secondarily infected.
Thank you, Dr. Woodley. Dr. Chen or Dr. Reusch, any further comments?
No.
You covered it, Dr. Woodley. No surprise. This question goes to you, Jordan, starting with a compliment and then 2 questions to follow. I've been following Wesson's Wish via EBRP updates, and the events always look fantastic. Does Jordan have any advice for a first-time event organizer, and how have you seen the landscape for EB change in the time since founding Wesson's Wish?
Wow. Okay. So that's a big question. First question is how to start an event, right?
Any advice?
To start from scratch.
First timers.
Yeah. I think that you need to have a huge goal. Honestly, I know huge goals are scary, but my brother, who's actually the one who developed our website, is someone who just told us, like, you just need to go for it. So if you think you want to raise $2,000, make it $10,000, and you won't. Especially, I just feel like God is within all of this with EB, and he hates EB, and he wants to find a cure. And so he's going to bless your works. And I think that you need to find something that your community and the people that you surround yourself with are interested in. Like doing a plunge in Houston is just not going to appeal to a lot of people because we're almost going to swim in the pool. So there's not a lot of attachment to the plunge because of just the weather we have down here. So finding something that really will relate to your community and your population of people would be my number one thing to say, and to not be scared about something that maybe you've never done before. Like golf is not in my wheelhouse. I've played other sports, but not golf. And so I just kind of was very vocal about learning as I go, and it's not going to be perfect every year. Literally before the event and at the event, I have a laundry list of things I want to change next year. So just know that it's not going to be perfect and that it'll just continue to get better as it goes on. And if you have any questions directly, feel free to find me on Instagram. I'll be happy to help in any way.
That's awesome, Jordan. And for those that have that question, you're the prime example, Jordan, of what a great entrepreneur is, truly, right? You've tried things, and if it works, you double down on it. If it doesn't, you try something else. And I think, it's putting the fun in fundraising, right? What does your community like to do? What will they enjoy? And so, yeah, you've been a prime example of that. So thank you, Jordan. This question is for Dr. Woodley, Dr. Chen, and Dr. Reusch. This is probably the most common we get as we talk about clinical trials and therapeutics and preclinical work, and it's for gentamicin and ataluren. Is there anything you can offer for the community several questions around just timing, right? When can we expect for these to be approved? And I know that's not an easy question to answer. The second part of that is what can this community do to help accelerate those timelines? So for gentamicin, for ataluren, how do you think about timelines of getting that official approval, and what can those on the line from families to other researchers and companies and donors and supporters do to help accelerate that as quickly as possible?
My understanding, I mean, you don't have to have FDA approval to use a medication for a certain disease that you think, as a doctor, it doesn't require FDA approval to use it. So this is a pretty rare disease, and actually going through the studies to really jump over the hoops that the FDA require would be a tall order. So, but I think doctors who see these patients can use gentamicin right now. It's available. It's inexpensive, and it's an old antibiotic, and we know the side effects, and we know how to screen for the side effects, including there's deafness as a possible side effect, kidney failure is a possible side effect, and you can test for those things periodically. So I think it's overall a relatively simple thing to monitor.
And
Yeah,
I think,
oh, go ahead.
I think for most patients now, we see a lot of inquiry about, okay, when the kid is diagnosed with IBD and junction EB, we also ask what's the protocol to use for IV gentamicin. So we usually give out the protocol adjustment, you need to monitor. So as long as the physician is willing to prescribe prescription, you don't need the FDA approval. So this is only FDA approved drug for antibiotic purpose.
Yeah, I echo what Dr. Woodley and Dr. Chen are saying about gentamicin. Dr. Chen actually helped me. I had one family who wanted to try the intramuscular gentamicin, and Dr. Chen kindly shared the USC protocol about the dosing and the frequency of the dosing so that I was able to use their protocol for a patient who was in the New England area without them having to travel to USC to officially be in the trial for it. And I had no problems from insurance about getting the gentamicin approved. The ataluren is a little bit more tricky because doesn't have an FDA indication for anything at this point. So you can't prescribe it as an off-label medicine. You really can't even prescribe it without going through all those hoops through the FDA and with the sponsor. I think that if our results from the next 3 patients are good, and there's interest in the community of continuing to move that forward, I think we can all be kind of a sounding cry together of doing what we can to get more availability.
Thank you, doctors. And you see some of the comments on the chat in addition to the responses I mentioned that we received in advance, and there's actually many on the call that can speak directly from exactly what you just said, is making gentamicin available as quickly as possible to those with junctional EB and recessive dystrophic EB in some cases. While we're on gentamicin, we received a question from a family member that had experience with gentamicin, and their clinic was hesitant in utilizing inhaled gentamicin. And Dr. Woodley and Dr. Chen, I know this is something that we've supported as part of our research funding that you've thought a lot about. The question from this family member was, has there been any added discussion about adding inhaled gentamicin to the protocols in addition to the topical and intravenous use?
So actually, when I was working for IV gentamicin with Richard and Tyler in Yale, is a pediatric dermatologist. Actually, he prescribed his patient with inhaled gentamicin, also simultaneously with IV gentamicin. So I think as long as it worked quite well, because a lot of these severe JD patients have a lot of problems with the airway. So if we use inhaled gentamicin, really make them feel better. So at the one time point, I was thinking doing maybe some inhaled gentamicin trial, small trial to test out, but I never realized. But people have been using, and also I have talked to the university majority that pediatric dermatology, they also use intelligent mice. I think you just need to know what dose, what concentration to use. I guess the Richard and Ty will provide, can give you more detail about those information.
Thank you. Thank you, Dr. Chen. Just to stay with the doctors for a moment, this is a question we've increasingly received, if not daily, frequently, but how has the recent government sanctions on research affected your studies? And if it has affected your studies, what are you doing to counter those sanctions? And how can donors specifically assist in continuing your efforts beyond just donations?
Yeah, that's a good question. And it's right now, we're not affected, but it could happen, any day if the politics continue like they're continuing now. But so far, we haven't had to face that.
I think a lot of project practice or something to do with DEI or as well doing with same thing with vaccine because so a lot of projects have some in those titles they will terminate you. So far we have not had that issue yet, but we don't know. Maybe along the way, maybe they cut more budget and we will. But that's why we always get the funding for EBRP. We continue our important project. A lot of this project, even you get an NIH funding, is difficult because they usually always do a little more basic research, but our study is very translation and patient oriented. So usually this project is not big enough for NIH, and not so that's why it's we appreciate we've been supported by EBRP for last 10 years or 12 years. So for continue all our study for last 12 years for research therapy. So we are very grateful for all you guys' support.
Thank you, Dr. Chen. Well, I know we are a little bit over time and the questions continue to flood in. As we mentioned, we'll take those questions in. We'll make sure that we're in touch with Dr. Reusch, Dr. Woodley, and Dr. Chen to get those questions answered and get back to you. This was, as expected, a topic that inspired many questions and much engagement from the community. So, my last question, which we've received in a couple different ways to each of you, Diana, Jordan, David, and Mei, is for the USC team, how can those on the line learn more and who can they contact to learn more about gentamicin and any additional trials? Diana, where can folks or where should they be in contact to learn more about your work at Adelora? And Jordan, where can folks visit to be involved with the amazing cornucopia of options to be involved with Wessons Wish? And maybe we'll start with you, Jordan.
Okay, well, our website I just put in the chat is www.wessonswish.com. And on there, I always update it with how much we've raised. And then there's an initiative page on there, which highlights all of our events and everything we've done. So all of that is kind of on there. I do have a Facebook group and an Instagram page as well, which again, if you just search Wessons Wish, it'll come up, and everything I do is on there. Wessons Wish is not my full-time. I'm also a mom full-time, and I also have another job too. So, but that stuff is on there and ready, available, and you can contact me through the website as well, and my email and everything is out there.
Thank you so much, Jordan. And just another tremendous thank you for your heroism and everything that you do to continue Wesson's legacy and all the additional families that you've inspired and really making possible the brilliant science that we've heard about today. So get involved. I have got some commitments as we sit on this call, Jordan, from some leadership from EBRP on the line. Jeff, Rick, and Nathan have agreed to come to the clay shoot. So
Yay.
Try not to get the Ask Last award, but you got some new tutors joining you next year, and all the events are remarkable. And you wouldn't know it, as Jordan said, that she does have other jobs. She does have children to care for, and is starting a new venture almost daily. But your work is nothing short of just inspiring, Jordan. So keep being vocal in your words, keep being loud, and know that we always have your back, and everybody on this line also has your back and support as well.
Thank you. And I just want to say thank you so much to all of you who are researching and helping everyone that has EB. Obviously, my son was not able to receive that help. And I know that was how it was supposed to play out. But I am just so thankful just listening to y'all and hearing. My background is actually pre-med degree. I'm not anywhere near y'all's level, but I actually understand some of the things y'all are talking about. And I'm just so impressed, and I don't really have the words to express my gratitude for y'all. So thank y'all so much.
Thank you, Jordan. Thank you so much. And you are making it possible, and which is a perfect segue. Dr. Woodley, Dr. Chen, how can folks get involved, learn more about gentamicin and all the great work you're doing at USC?
I hope people know this organization called DEBRA, because we often keep in contact with the leadership of DEBRA, and if we have some new finding or need patient participation, we do it through the DEBRA organization.
Now, also the patient, usually all the physicians always can email me directly, and I usually provide them all the details that they want to do. So they can find my email address in my paper, or I can send to you, and you can let them contact me directly with email.
Thank you, Dr. Chen. And I know that that's been true. As we mentioned, many on the phone have been in touch with you directly, and you've been able to help their children. And, we are always honored to support the work at USC. And as I said, it's been one of our longest term funding commitments to be a sole funder of that work and those projects. And so every donor on the call, that is another way to help, right? Support EBRP so we can continue to support the important work at USC. And Dr. Reusch, how about those that want to learn more about Adelorin or your work at UMass? How can they be in touch?
Yeah, I've just put our team's email in the chat. So happy to hear from anyone.
Awesome. Well, thank you so much for everybody's time for joining today. Another great town hall, another great session. As you heard Dr. Woodley, Dr. Chen, and Dr. Reusch say, regardless of what's going on with government, regardless of what's going on in the world, the way that we can support is to continue to support EBRP, to fund the science, to fund the clinical trials, and to fund the work of these brilliant organizations to continue to advance our mission, which is to treat and cure EB. And so thank you for your support. There's lots of ways to get involved. We have another town hall coming up next month with TWI to talk about diacerin and EB simplex, another subtype that we will cover in April. As I mentioned at the top of the hour, we've got a research cycle that is currently under review, one of the biggest research cycles that we've ever had, almost $4 million in asks, 10 projects from across the world, almost half being by medical definition curative. So we will fund as much research as we raise the dollars to do. So get involved. Another shout out to Dr. Jeff Heddles, who's on the line, and another reminder, thanks to Jeff, every single dollar up to $250,000 is being matched. So your $1 becomes $2. So if you were waiting for a time to get involved, now is the time. You can double your donation and double your impact. The plunge season is upon us. You heard from Faye. We've got Stephen Kubik on the line. Plunges are happening in 22 locations across the globe. We just had plunges in Wellesley and Staten Island. Thank you again, Faye. And thank you, Emily. There's plunges this weekend in Seattle, in Melbourne, Australia, and really plunges going on for the next 2 months. So find one near you. If there's not one near you, organize your own. If you don't want to organize your own, just simply find a body of water that you can jump in and plunge virtually at home. So lots of ways to get involved. Thank you, everybody, for your time today. Please be in touch with any questions that we didn't answer. The ones that we didn't have time to get to, we will make sure that we respond and get back to you. And again, I just want to take a moment to look around at this call. We have board members. I see our founder, Jill Vetter, has joined, and we thank her for her leadership and really her brilliance to elevate the platform and awareness for EB unlike any other that's come before her and come since. So thank you, Jill. Thank you to the board members. Thank you to the doctors on the line, researchers, clinicians, companies, and most importantly, our True North, all the families, all the parents that are on this line. You are the reason why we do what we do. So I will end in the words of Jordan Eaves, which is, be loud, use your voice, rally your community, and we thank you all for your time today.